The next question for our specific case is what to do in terms of systemic therapy options. So we always rely on two major factors, the overall clinical condition, and this patient has remained in good clinical condition with good performance and nutritional status. The next question is the status of the underlying liver disease and the liver function studies. So as long as the patient is stable from that standpoint as well, and by stable I mean according to their baseline, could this patient remain in Child-Pugh B? However, if the bilirubin is also still around 3 and the patient is in good condition, should we start third-line therapy? So this is also something that we tailor according to every specific case, look at it from the multidisciplinary approach, if there is any options in terms of local or systemic for every individual. So for this specific patient, agents that could be considered in a multidisciplinary manner, one of them could be cabozantinib. It's a tyrosine kinase inhibitor, recently approved in second-line setting, and this study included patients who underwent 2+ lines of therapy. Although the number was small, but it was a proof of concept that you could include patients who progressed on more than 1 line of therapy. So based on that, a lot of practices follow this rationale to start cabozantinib beyond front and second line setting. However, as I mentioned, it has to be done with extreme caution regarding the liver function status assessment, regarding portal hypertension and esophageal varices assessment to make sure that we're not introducing more harm than benefit to our patient. So in this specific case, it has to be tailored to the patient clinical condition, status of the underlying liver disease at the time of starting therapy with frequent monitoring. And again, some practices, including mine, will also go with a lower dose upfront to make sure the patient is handling it well and the liver functions are stable and lower dose. So this is not in the guidelines, but however, those patients, as I mentioned earlier, they get excluded from clinical trials if they have underlying liver disease manifested by Child-Pugh B class. So in general, we tailor our treatment to those patients based on local expertise and a team approach, including oncologists and hepatologists. So this is a very typical scenario to what the specifically community physicians have to face. Academic centers usually serve as a tertiary care center where we get most of our referrals from oncologists, so most of them are Child-Pugh A and fit for therapy and for clinical trials. However, a real case scenario is patients with advanced liver disease and Child-Pugh B, so that's why it has to be individualized based on the risk-benefit ratio. Currently, targeted therapy in the second line space have been expanded recently. So we have regorafenib in the second line setting after progression on sorafenib. We have cabozantinib after progression on sorafenib, and also included some patients who had 2+ lines of therapies. And then we have ramucirumab, which is approved for patients with alpha-fetoprotein equal to or more than 400. So options for frontline and second line HCC have been expanded recently, and therefore it became a busy field. And in my practice, as well as a lot of oncologists who manage HCC, you tailor the treatment based on the patient general condition, some signals in frontline, as we have mentioned, sorafenib versus lenvatinib, depending on the hepatitis status. But again, this is based on meta-analysis and subset analysis, so they are not yet among the guidelines, but this is just individual preferences that we discuss with our patients. And in second line setting, again, the same rationale to pick and choose which drug depending on the tolerance to tyrosine kinase inhibitors, for example, and also the clinical condition and liver function status. In HCC has never been addressed in clinical trials in a systematic way. There is no dedicated studies reported yet in a randomized fashion to look into third line, but there will be. Up until this point, if you look at the second line clinical trials, most of them excluded patients with 2+ lines except cabozantinib. Study that also included some patients who underwent 2+ frontline therapies, frontlines followed by second line, and then this study was considered a third line for them. The small number didn't really address the issue of third line. However, some physicians rely on that to advance their patients after progression on front and second line to cabozantinib. It's a tyrosine kinase inhibitor, strong anti-angiogenesis. In my practice, if I'm starting cabozantinib for one of my patients, I always use extreme caution in terms of assessing risk of bleeding, for example. So we order upper endoscopies for our patients to evaluate their varices, and this is not just for cabozantinib. I do this for all strong anti-angiogenesis and TKIs and targeted therapies in HCC, and also manage hypertension, assess their cardiac risk. In general, our patients also could be suffering from poor nutrition, low albumin, so we address that as well, because most of the tyrosine kinase inhibitors could affect nutrition, could affect their appetite and energy level. So we manage it in a multidisciplinary manner with our dietitian, our physical therapist. We involve our supportive care team on board upfront to prepare our patients to start targeted therapies, and also while on treatment to co-manage those side effects and address issues related to malnutrition, for example, with our dietitian, or lack of physical activity with a program that could involve physical therapy. So it's a team approach in this era of HCC based on the side effects record of targeted therapies.